are live with this special edition of Virtually Connecting and ePatients. I'm Rebecca Hogue. I'm going to be your host today. I'll do a quick introduction. I am co-founder of Virtually Connecting, but professionally I'm also an instructor. I'm a lecturer at UMass Boston, teaching in the instructional design program, and a PhD student at the University of Ottawa, where I'm currently studying breast cancer blogs in the breast cancer blogosphere. And the reason I got into that is because I'm also a breast cancer survivor. And so I went through, and when I was diagnosed, I had to blog. It was a compulsion for me. It's like I'd been a blogger elsewhere. I had to write it down. So I started my blog, bcbecky.com, and blogged all through. So I'm at almost 500 posts now after 2 years, and I just hit my 2-year diagnosis anniversary a couple days ago. So that's a little bit about me, and I'm going to pass it over, and I see Susan next on my screen. So over to you, Susan.
All right, thank you. I'm Susan Adams, and I'm an instructional designer and faculty development specialist at Oregon Health and Science University. My primary focus is on the Registered Nurse Bachelor of Science fully online program. And they are very interested as a faculty cohort. It's a very strong cohort in patient engagement and the movement that's behind it. And they have not done a lot of social media in the curriculum, so part of my charge recently has been to explore that. And then I'm taking it to the next level, which is this conversation around how we weave this in for patient connection. In terms of my own experience as a social media person now with my own blogging, it's a very compelling story for me to be involved in this conversation. I've invited some of my faculty, hope they might be able to show up today, but if not, I'm happy to bring the information back to them and have this conversation continue.
All right, Brittany?
Hi, so I guess I'll start with the e-patient side because this is what, we're talking about. I've been blogging about my journey with trying to come to diagnosis and managing healthcare conditions at the best flyer you know on WordPress. I have for sure diagnosed endometriosis and recently gastroparesis and a whole host of other things that we just don't know what's going on. And I'm always my doctor's worst nightmare because I am a very engaged patient and a PhD student with access to journals and a background in animal science. So I show up with journal articles and I'm like, let's talk about this. That's why I still have a gallbladder. So I am a PhD student in instructional design, and I'd really love to use the instructional design to help bridge the gap between me as a patient and the other, other people, the medical side too.
Excellent. And over to you, Autumn.
Hey guys, I'm Autumn Keynes, and I am in Columbus, Ohio. I work at Capital University as the Associate Director of Academic Technology at Capital University. And I'm kind of the odd man out in the fact that I don't have any kind of medical background. We do have a nursing school here at Capital, and I support those folks pretty closely. But I have deep interests in the idea of digital citizenship, and I think that there can be a huge case made for ePatients in terms of being a good digital citizen and what that means. And I think Rebecca also keeps me around because I ask novel little questions like, what is an ePatient exactly? So I don't know a lot, but I'm here to listen and learn and ask some questions. So thanks for having me.
Right. So actually, Autumn, you just brought up the first sort of question that I wanted to put out there is, what does ePatient mean to other people? And we've heard the word engaged, but also actually ePatient Dave tweeted out a couple of other terms like empowered. There were 2 others that I'm always forgetting. And different sort of, but it's all along the same lines. But what does it mean to be an ePatient, and do you have to be an advocate if you're an ePatient? What's the equivalent? What do those things mean? And I'm going to throw that out to you. Do you guys have any thoughts on that?
I'd say you definitely have to be an advocate, whether it's just for your own health. Like, I've had to be an advocate many times with some rare diagnosis or for treatment models or things like that. So it might not necessarily be like a social advocate, although I'm all for that too, but you definitely at least have to be an advocate for yourself and be prepared to not just accept whatever you are told and stand up with people. I like empowered as well. If you think of those other E words, let us know.
Yeah, I was going to go look up that tweet and see where it is, because I think I wrote something about it at some point.
I'm curious about the word advocate, Brittany, in terms of advocating for yourself as a patient or advocating in general in the world kind of politically. I guess that's where my brain went, and I just wanted to see if there's a distinction there or if it encompasses both.
I encompass both, but I know there's other people who probably just advocate for themselves as a patient, because you have to do a lot of advocating as a patient. Particularly, like with my endometriosis, I've had to do a lot of advocating for my own rights. It took me 10 years to get diagnosed, and a lot of that was just pushing doctors to, okay, yes, we've done this, can we finally go to the surgery to diagnose this? And then they wanted, oh, well, let's test this for another 3 months. Well, okay, knocking out my estrogen, we can do that, but we really need to actually get it and find it, or things like that. Or with my newest diagnosis, the gastroparesis, I wouldn't have been diagnosed. My gastroenterologist threw up her hands and was like, I don't know what to do with you. And I had to keep pushing with my internist, actually, to be like, okay, like, I'm not eating. I can't eat. Something's going wrong, and finally get that diagnosis. So I have to advocate for myself and not just let them roll over. But I also think politically advocating is important. So with endometriosis, I support, like endo awareness and stuff like that. And I'm still new to the gastroparesis world, so I'm figuring that one out.
Right.
I can totally relate to your, first of all, the multiple diagnosis thing, right? So I'm a breast cancer survivor, but I also have celiac disease. And that's a more recent diagnosis. And so I've gone through a lot of the process of figuring out what this means, going through all of that. It's a genetic disease. So in my case, my father has it, and it's in the end going to kill him because he went untreated for so long, but also uncompliant, in part because my parents were never educated about what it means. And the first gastroenterologist I saw said, "Look at the internet. Go look it up on the internet." That's the advice he gave me. He says, "Yeah, you probably have celiac disease. Go look it up on the internet." And
that's more I've done for all of my diagnoses.
Whereas in the cancer world, they tell you don't look at the internet, which I think is also really bad advice, right? You come in and they say you have breast cancer, but don't look it up on the internet. That'll scare you. What? No, it'll tell me what I need to know. But you have to know how to look things up on the internet, and I think that's sort of where that comes. And so some of the other words were equipped and enabled, were the other two E ones. And I think equipped sounds like a good one. And Susan just texted something, so I'll let you say it, Susan, because that doesn't show up on the screen.
Well, I want to allow you to facilitate this conversation, but equipped really struck me. What does it mean to be equipped? And I really I'm very curious about this conversation going into how do patients have be equipped to actually digitally connect, right? Eventually we're sort of talking about, there's equipped as in, Brittany, clearly you are equipped with an ability to be forthright, to be communicative, to, it sounds like, be pretty direct, right? And that's a skill set, I would say, right? I mean, that's something that you have in you, that's natural to you. And I think patients are all going to be on a spectrum there. And so when I think about going to the digital spaces, right, connecting in social media as a patient through blogging, and then potentially with the V-Connecting platform, I don't know if I have my formulated question yet, but I'm looking into what kinds of capacities and literacies can we support patients to have to be at the space where they can get what they need. They don't necessarily have to be as direct, or I mean, you can get to these places being who you are, but that invitation and connecting into that network takes some literacy.
It's actually a cultural shift as well. And so what we find, like if I look at the blogosphere, most of the people that are blogging are highly educated. There's a disproportionate number of people who have PhDs or master's degrees that are blogging about illness, right? And, say Brittany and I are the case, right? Case in point, who comes here, right? Which meant that we also have access to the databases. And that's actually a really big issue in the ePatient space, is people have access to the abstracts of the papers, but they don't get access to the full papers.
Oh yeah, I don't know what I'd do without PubMed.
Yeah,
There's definitely been times I've sorted like surgery. They wanted to take my gallbladder out, and it was like, look, this paper literally says 40% of the cases. Like, we're not doing surgery because of one test. Let's
step back.
Let's step back a minute.
Yeah, and that's in some ways it's a good thing. For me, it was for the first while I couldn't do it. My husband did. I gave him my access code, so I'm like, this is what you need, because he was reading all of the papers for me and distilling them, so that I didn't have to read the bad stuff. Because when you're given a cancer diagnosis, that's pretty harsh. But it so it took a while for me to get equipped enough mentally to handle it myself. And I think that that's part of the sort of interesting challenges that happen with sort of the ePatient community. But I think the cultural shift is a big one, because, again, older generations, and I hate to generationalize things, but I look at this in the care that my parents are getting. They don't know how to be that squeaky wheel, right? It doesn't occur to them that they should be the ones phoning the doctor's office every day to get that appointment moved up. Right.
Or should they? I mean, I think that's where it's like, in some senses we could honor the fact that they don't have those literacies and create advocacy around that with their families and or with what we might talk about today, and some kind of a program or something that allows us to have family members who are in the waiting rooms, right, gain access to this. I think could be a real great solution, or a possible solution to those generational gaps to the literacy.
Well, you bring up an interesting point, because I think that the caregiver space is actually a pretty interesting one as well. Because if they're not in the appointments, they're sitting in the waiting rooms. And again, you've got that time. Like, I think about my infusions when I was going through chemo. My husband came with me for every single one of them. We both sat in front of our laptops for 4 hours while we were going through that process. But that time, I guess I'm a little bit torn there, because part of what happens in the e-space, and especially with bloggers, and somebody commented on my blog on this the other day when I was asking about researchers using blog data as data for the research. One of the challenges is that bloggers put a lot of time, like ePatients put a lot of time and effort in, that is completely not compensated. And then other people go and use that data, and as if it were, because it's on the public internet, freely available for them to just use that data, with sometimes not even a mention of the URLs that they used, right? There's no thanking, there's no mention of all of that effort, that social, like that time and effort that goes into it. And this is what happens in the advocacy space. But what also is happening, and we saw even with this conversation here, people, not able to make it because the advocates that are out there doing it are so busy, because there's so few that are equipped that actually can make a difference and can have intelligent conversations across the board. I'm going in so many directions with my thoughts right now.
No, I think it's important. I appreciate and have still an inspiration, and maybe I'm the eternal optimist here, but if it is offered, they will come on some level. I get the busyness and I get the sort of uncertainty, but it's almost like a swirl, or the idea of diffusion of innovations, right? Like if we can get folks, even one or two, to be change agents or have an experience where they connected in these spaces in a positive way, it could save someone's life. It could change someone's life to them saving their life. And I think this is, the reconnecting space is so new, and even social media is new for a lot of people in terms of being intentional about their usage of it. And I remain so excited about how we can educate people to consider their digital spaces a supportive environment beyond the blogosphere, even, and how we can continue to do that.
So in the breast cancer space, there are a few significant social media communities. Right. There's BCSM, which is a Twitter community. It's been going on for quite some time, but is very, very well supported, which means that any woman at any time can tweet to BCSM, Breast Cancer Social Media. And somebody, you tweet a question out there and somebody will be there to answer it. And somebody will be there to answer it with evidence-based comments. It's not just commentary. There are doctors that follow that. There are caregivers that follow that. There are advocates that follow that. So there are actually important, you can get really, really good information there. But then there's also really good Facebook groups. And so if you're on Facebook, right, so when I wanted to not do reconstruction, there's a Facebook group called Flat and Fabulous. It's a great support structure for anybody who's making the choice not to reconstruct after breast cancer, and how to live with that, and how to be happy with your body and who you are, and how to cope with the different, stupidities of people who don't understand the problem, right? So the support communities are there. And then there's other support communities for the type of surgery I had, right? So I did a reconstruction, and there's a deep flap support community for people that have had the type of reconstruction I had. So it meant that I could go in there and ask them, well, is this normal, right? And quite often that peer-to-peer patient is this normal ability reduces the strain on the nurses and the nurse advocates and stuff like that, because somebody come back and say, yeah, that's normal. You don't need to worry about that. Mm-hmm. And it also really helps women calm down, right? Because you have that immediate, oh my God, I'm going to die stress that happens, or this is going to fail, or this is going to be a problem, and being able to have that support in there. So the challenge comes in some places. So one of the things that I guess I wanted to bridge this over to is what I'm seeing in the ePatient community, a couple of key things that I think that I'd like to see changed, one of which is, patients are great at talking to other patients and providing peer support for each other. And nurses talk to nurses and doctors talk to doctors. And when we go to conferences, we have conferences for each of them. But Health 2.0 last year was a classic example. They put the patient advocate stream at the same time as the provider education stream, which meant that physicians had to choose between whether they wanted to hear the patient experience or whether they wanted to get their own professional development. They couldn't be, and it's like, wait a second, these things should be at different times so that patients can be in the professional development and doctors can be in the patient stream, so that we're not siloing each other and we're actually talking to each other. And so one of the things I'd love to see V-Connecting look at is, can we bring together people from the silos to have this conversation? And then the other aspect is, can we get patients to a point where they can have a meaningful conversation here? Because part of the challenge, too, is we talk about patient advocacy. There's a big move for patients included at conferences. And what happens is, if you're not, if you're a patient, sometimes like they pick patients and they go to the conference, but they know nothing about the disease. They know nothing about what they're doing. They can't have that intelligent conversation yet. So they're not really effective advocates, and they're given space to speak, but no one listens to what they have to say because they haven't figured out the language they need to use to effectively communicate across the paradigms. It's like researchers don't want to talk to patients who don't understand the difference between personal experience and generalized experience, right? This is your personal problem, you versus this is a problem that everybody or most people with your disease have, right? Those two things, and if people can't make that leap, the researchers aren't necessarily interested in hearing it. And so they get given space to speak, but it's a different form of oppression, really. Space to speak, but not really listened to.
Do you think we need to advocate for researchers to be better educators, or at least have that as a value-laden approach to how they are in the world, even, right? To not sort of, I mean, is that partly, I don't want to point fingers because I think we're in a cultural situation here, right? And I guess that's what I'm like, what would be the best scenario in that crossover of a researcher speaking to a patient?
Does it come back to listening?
That's what I was thinking.
Because that's what I tied on to so quickly when Rebecca was talking, is that we can give them a place to talk, but do we really listen to them? And that goes back to my interests in digital citizenship and thinking of listening as a form of participation, and realizing that there's different types of listening. There's active listening, there's passive listening, and then there's surveillance too, right? That's a form of listening, which is a little weird and like Big Brother-ish, but there's different, and I don't know, I guess I'd have to look at the research on that, but how do we listen better, and especially in a medical situation, because that seems like a really important place to know how to listen.
And also not write people off. Oh, they don't know, right?
Mm-hmm.
I think listening also, the active listening is meeting people where they're at and having the astute ability to say, okay, if they're here, this is what I can say and talk to, and this is how they're going to understand. Even that little piece just would make all the difference to building people's capacity for interest and continued curiosity, because it does take a sustained level of curiosity with all the emotions going on in a diagnosis to be able to really get into the science of it from a researcher standpoint, for example.
Do we train nurses and doctors in the art of listening? Is there curriculum around that?
Our R&BS program this senior year is very much geared towards ethics and leadership and advocacy, a lot around patient handoff and other things. But that is very much why there's a push to have registered nurses get a Bachelor of Science, is to really gain that leadership, both in policy work, but I think in that listening and empathy is fantastic too. And hopefully is also part of that curriculum. I know it is at our institution, and could certainly be more.
Wish it was more prevalent. Had a lot of doctors who don't listen. Nurses are generally better.
I feel like I've experienced some of that, unfortunately, in some medical care that I've seen, either for myself. But I think it also comes back to this idea of advocacy. And I felt Rebecca so much when she was talking about, can you really advocate for yourself when you're dealing with a diagnosis and all of the emotions that come with something like that? And how do we identify who is the advocate at that point? Like, I think in, best case scenario, you could be your own advocate, but what happens when you can't be your own advocate, either because the emotional weight from the diagnosis is so heavy, or because you're too young to be your own advocate, or you're too old to be your own advocate, or you're dealing with a mental illness where you can't be your own advocate? That's messy stuff. Or when you're drugged up.
Yeah, when you're drugged up. There's lots of times, I think when you say that, and I think to the time where I just came out of surgery, and, my husband had to be my advocate at that point because I was just not mentally capable of being my own advocate. And I remember fighting for something because it wasn't right, and my husband wasn't there, and I'm like, I'm trying to stay awake long enough to fight for it. But it actually comes to an issue that's happening in the metastatic breast cancer community, because they're really trying to advocate for more research in that space because it's metastatic breast cancer that kills. The problem is people that have metastatic breast cancer are in perpetual treatment, which means that they're always going through chemotherapy. They're always going through various things. So they're, they have good days and then they have a lot of bad days. And they're not, so they're a community where they're trying to advocate, but they're making baby steps because they need people that are healthier, that are in a position to carry on the continuity for them. And so it's a really challenging, and I think this is part of I want to throw out a term, and I can't remember somebody, I did pick it up from the blogosphere, and I did quote it in my blog, so my blog will say who said it, is healthy privilege. And the idea that a lot of the policies and a lot of the things are set by people with healthy privilege. Like when I hear things like Medicare has a cap on the amount of drugs, the amount that they will pay for drugs for a given patient in a year, right? How ridiculous is that, right? Somebody with a chronic illness is going to need more medication, and they're going to hit the cap, but they're already financially strained because they have a chronic illness. This is a policy set by somebody who's completely healthy and has no sense of what it means not to be. And so that healthy privilege like reeks through the medical system. And it's sort of part of what patients or advocates, specifically vocal patients or patient advocates, because not every patient is meant to be out in the public limelight sharing their life and advocating, right? Not everybody wants that.
And I think that's important to remember. We're not pushing people to say this is what you're supposed to do. You'll gain so much from it. Not at all. It's simply finding those folks that really need it and advocating for the possibility of change and exchange to happen for them. Yeah, I think those policies and that are hamstringing and almost handcuffing patients in a way that's very oppressive, such as the chronic illness and the financial decisions being made around that. Part of the connecting to a network can be a building of changing that, right? It could be kind of a default where it's not the main driver, but it could be part of what could happen as a optimistic outcome to people connecting more in the blogosphere and more intentionally to that end. But I really like the notion of going back to these conferences, because I think a lot of conferences, even in the ed tech space, the educational tech space is going, where are the students? They're not here at these conferences. And we often don't have faculty at the conferences. We have instructional designers at the ed tech conferences and CIOs. So it's a similar sort of question as we are evolving our participation in our membership organizations everywhere to begin to ask the question, who's at the table? And when we're at the table, particularly this, I kind of want to get back to how do we teach the listening and the empathy and create spaces at those conferences for those emotional conversations to be happening, or even the skill base of teaching people how to be present in those conferences to be better listeners. A lot of people that were going to be on this call are very active in conferences in the telehealth space, and I think I am excited to continue conversations with them to say, how are these conferences being organized?
I think you sort of hit on something that, I'm trying to figure out how do we as Virtually Connecting do something in this space. Is it conference connected? Is it missed conversations type thing? Like, I wonder what you guys think. Where can we do something that adds value in this space?
Well, I think one of the things that Virtually Connecting does well is we create liminal spaces at conferences, right? And a lot of conferences don't, I'm hesitating to say this, but I'm going to say it anyway. They don't value those in-between spaces. They pack the schedule with keynote speaker backed up right against concurrent session, backed up right against lunch, backed up right against concurrent session, backed up right, and maybe 10, 15 minutes in between to get from one place to the other. And we kind of come in and we sort of force a space in there, and we say, okay, well, we need a half an hour to do something, and maybe we fit it at the end, maybe we extend one of those breaks a little bit and somebody ends up, kind of going late to something, or maybe we do something early in the morning and do like a breakfast session kind of thing. But those liminal spaces, those in-between spaces of time at a conference are really important, I think, especially in the type of space where you're talking about, Rebecca, where it's really siloed, where you have those multiple constituencies, but they're not overlapping and they're not connecting with one another. And if we can create a space, an in-between space, where we could bring those multiple constituencies together, especially people who couldn't make it to the conference because of logistics, money, family, illness, right? I think that could be really powerful. I'd say focus on bringing those different constituencies to the same table and using technology to facilitate that.
Oh, I just applaud that, Autumn. Thank you. I love the notion of liminal spaces, and I think it's something people are still learning how to do. And I love that we can paint the picture of that possibility. And I think that's what this call is about, is really the first spark of saying, we're here and this is possible. Where can this fit in an appropriate and a collegiate agreement to provide this opportunity for people? I'm very excited about the possibilities. And I think what you just described is what has been hard for Rebecca and I. We've been kind of reaching out a little bit, even just this week, and realizing people are very confused about what virtually connecting is. And you just described much more clearly, even for us, how that works and how that could work at a telehealth, if I'm even using that right, conference. Yeah.
I think part of it is finding the right connections, because we're talking conference again, but which isn't necessarily a bad thing, but finding the right, excuse me, finding a conference or finding the situation where we can get people. Like, I know I tried, Stacy was going to try and do something at ASCO, but we just couldn't get that together. Now, ASCO is crazy. That's the American Association of Clinical Oncology Conference, and it is over 30,000 people at it. Mm-hmm. So that's big on a ridiculous scale. and trying to get even decent Wi-Fi was a challenge. Mm-hmm. But part of it is we need to get some people that are actually physically on the ground. Mm-hmm. To be willing to help create that liminal space.
And I like your idea. Okay, so exploring the non-conference space, because you're right, the conference space is very structured. The non-conference space, again, I'm new to it, and this is where, I want to get some nurses to the table and some healthcare practitioners in hospitals to say, could we give an iPad to a patient who is awake and, in the hospital for a week, and provide them with some education around digital literacy and some connections to start blogging? I mean, is that even, is that a space that we could be in? Like, I'm so curious about where that could work, and that does take a cultural shift. Or in a doctor's office, in the waiting room, that there's a pamphlet, or there's sort of, we're not trying to sell virtual connecting by any means. It's not at all what this is. This is a volunteer effort of educating to equip patients. And where do we find them and meet them to build some kind of an infrastructure of educating them and equipping them?
I was just thinking maybe what we need is a virtually connecting ePatient talk show. where, like, because part of the thing I wanted to get at is that we don't need another webinar. We don't need another lecture. We don't need that kind of information. What we need is conversations. And so we need to facilitate a space where we can have conversations. Because there is learning theory behind that we actually learn through that conversation space. But I also think that there's really value in that connecting. And we go back to the pre-show conversation we had before we went live about sort of the idea of badging and analyzing. So we could do like a virtually connecting YouTube talk show where anybody who attends gets a badge, and then we could do some sort of interesting map analysis or whatever, and then eventually tie that into like what brings people to the table. Like, so medical professionals, what's going to bring them to the table is CME credits, continuing medical education credits. They have to get a certain number of credits every year to maintain their professional thing. And if we can get tied, first of all, create the conversation, and then eventually get tied into, you come and join a conversation and you get credit, that gives us the motivator to get the medical professionals in. We might be able to get the med students in. So my background, I've worked with medical education, and when I say medical education, I mean doctors, physician education. I'm not familiar with health provider, so the other roles like nursing and that, which is actually good because I think we got a great balance here in the conversation. But I think that might be an interesting, I don't know, what do you guys think?
My only thought is to be careful of the talk show format. I just call it conversation and keep the focus on education. I think when you call it a talk show, you do a couple of things. On the positive side, I think you make it something that people can relate to, right? And they kind of think, oh, well, I understand what that is. I've seen a talk show. I've listened to a podcast. But it also sets up an expectation of a certain amount of polish that I don't like. Like, and I think this goes back to some of Virtually Connecting's roots. I want it to be an organic conversation. I don't want it to feel like the polish is coming before the content. The content should be the most, the connections should actually be the most important part, right? The people meeting each other and knowing each other. But I think that the polish can get in the way of the connections because then it feels fake.
I totally agree. I think back to the manifesto for Virtually Connecting, and I added the last line in there when we were first putting it together: embrace imperfection, because I think that part of what makes this work is the authenticity of it all. And the minute we try and overproduce something, then we're going back into that webinar educational space, and that space is already there. Like, we don't need to replicate that. What's missing is the ability for people to actually talk to each other. And so, but here the big question comes up, is how do we get people to the table in the first place? Do we need to use a topic as a way in which to get them to the table so that we can have the conversation? Because I think that that's part of the challenge. We can't just say we want people to come in and talk, which is what we do want, but we have to give them a reason to be there. Otherwise, it's never going to hit their priority list. They're never going to make it into the conversation. So I'm wondering what you guys think of how we do that.
I think that'll come down to framing too. Like, we'll have to frame it. Are we framing it? I mean, it's a conversation, so both parties are getting something out of it. But is practitioners coming in thinking, oh, this is primarily educating patients, and then I'm getting some reciprocal, or patients primarily coming in, I'm letting my doctor know my side. We'd have to find that balance between expectations, I think. that'd be a tricky one to navigate, but important.
I think there's a modeling that gets to happen with that too, Brittany, which is what I've experienced in my first V Connecting. I was very nervous, right? But I watched how the facilitator delivered questions, and so there was kind of a modeling that occurred that helps me to see and invited my own authentic voice instead of being so formal, right? But you're right, it takes that framing and leadership of that framing. Which can invite it naturally. And I love the idea of framing it as the word conversation rather than talk show.
And I guess I can only speak to my experience of doing virtually connecting for the past year, right? And so maybe not necessarily so much in the ePatient, and there might be things about, so I guess this is my disclaimer, right? There might be things about that particular landscape that you know I'm not as up to date on. One of the things that I think has been a struggle for virtually connecting, but I think that it makes it I think it's a really important point, is the focus on people instead of topics. Right, and so I mean, you could do that. You could have a you know, famous researcher or whatever on the conversation that particular day, and I think that would be a draw. I think that would bring people in, and that would help them to prioritize it. At the same time, that creates a little bit of a power dynamic that some people don't like so much, right? And they start saying, "Oh, it's clicky," or "Oh, it's you know, you're just creating a, you know, a platform for famous people to spout off," and then it goes back to being a show instead of a conversation, right? I think topics are another great way to get people to prioritize and get people to put some framing around the around the conversation. And we haven't done that as much with virtually connecting, but I'm totally open to that. I think that that's a great way. At the end of the day, for me, it comes back to creating connections and trying to connect people to one another. I met so many people through virtually connecting and learned so much. And for me, it's about the people, but how do you get people to the table? And if you've got to do that with a topic, then do it with a topic. If you got to do that with a person, do it with a person. If you've got to do it around an event, like a conference or something like that that's bringing people together, then do it around an event. I'm kind of agnostic as far as how you do that. I just think you need to focus on the connections at the end of the day.
Great point, Autumn, and I think that's what makes us different, you know, than what's already out there. And I think that's super important because we're filling a need. We're not even necessarily trying to be different. We're filling a need because we see so many of these polished things and drivers for trying to sell products and other motivations, that it's just nice to get back down to the people and the authenticity and invite the possibility of these digital spaces being human, which swings it right back around to digital citizenship. And I think that's what makes virtually connecting the possibilities endless, to get into these different fields, to provide this human layer to how we inhabit our digital spaces.
I mean, health is a huge part of having a good citizenry, right? You can't have a sick citizenry. You can't have a citizenry that is filled with people who are physically or mentally or, you know, in any of these levels ill on a you know, a chronic basis. You need to have healthy people, and of course we're going to have sickness in our society, but we need to work toward health together, and we need to do that. You know, we need to take some responsibility for that as a society.
Thinking about sort of the getting people to the table, I was thinking, I wonder if we want to look at some existing social media communities and use that as a launching point, because they're connected online, so we already have a digital citizenship, like a digital space, and we've got to start with something, some basic starting point. and then from there launch into, let's have a virtually connecting, and I'm going to throw the communities I know, right? So for example, I could ask the BCSM folks, would you like to do a virtually connecting conversation? We will, have up to 10 people, well, 8, because I think we need 2 facilitators on our end. And I think that, not being in this space makes you a great place for a facilitator, because then you can ask the questions that everybody else in the world doesn't know the answer to, right? And it helps break the insider speak that would happen when you ask a community like that, because the community would be very full of people that understood the community. But I think that might be a good place to start and then balloon out from, maybe. I could also ask bloggers, because that's another community.
I think each one of us could pick a community to approach within our own spheres. And I'm actually going to take one step back from it and just take this video that we're recording right now and actually use it in a staff meeting at RMBS and ask, that entire cohort here at OHSU, what spaces would you recommend we approach and to possibly start this as well. So I think that's a kind of a research thing that I'd be willing and want to do as well. Because again, we have to explain what this is and sort of getting ourselves around the framing Brittany's talking about and what Autumn has articulated down to some sound bites for ourselves to easily transfer it, but also invite someone to watch this video, I think is a great first step for myself that I want to commit to.
I think starting with those communities already would be good, because they've already reached a point where the hierarchy of like doctor-patient's already kind of disrupted. So they're already kind of more used to, they're not going to come in and expect, being lectured or talking at someone. They're going to be more aware of the communication, and that can kind of lead to a bridge to see, well, this is how communicating, how being peers works, right? We're kind of all privileged being doc students or docs that we're used to being peers with everyone we're talking with, because that's kind of how grad school sets you up. But you walk into a doctor's office and you sure don't feel like a peer. Even if you have background, like my master's is in physiology of reproduction, and I can't tell you how many reproductive endocrinologists I've been to who like to talk down to me. I'm like, cool, I have a master's in this. I do know what I'm talking about. Like, we could have some peer level conversations here, and I think breaking that preconceived barrier with those already established groups would go a long way.
Oh, I love that, Brittany. Thank you. That's a great point and an important one. Being really transparent about who you are and where you are and inviting, hey, we can have a peer-to-peer conversation. What do you think of that? Awesome.
I think that's a great idea to reach out to already existing communities and think about how we can create events around that. So, I kind of think that what we're doing right now is an event, right? We're creating an event together. So we can tie ourselves to events that are already happening, like a conference or a class or whatever. And we've done that in the past, but maybe we need to create the event in a community that's already established. So there's like an online community that's already established. Approach them and say, hey, can we create a virtual event with you? And create a space where we can bring in the players, the actors, the people who would normally not talk to each other. And create an event and a space and a place for them to have some cross-dialogue, because we're seeing a need for that. And maybe it's more than one community. Maybe we approach like a community of patients, and we approach a community of doctors, and we say, hey, can we bring you guys together? Or a community of nurses or whatever, and say, hey, can we create, again, that liminal space? Can we create that in-between space that you guys don't usually have that crosstalk with each other? And, we have to embrace the hospitality and make it friendly for everybody, make it something that people are going to feel comfortable in. I would see a lot of value in that. Again, this isn't my realm, but that's where I'm at.
See, I think one of the key things that Brittany mentioned, and I think it's really important, is some of these social media communities have already figured that out, right? They've figured out how to speak to each other across all things and how to have that respectful conversation, that peer conversation. And so I think that starting with modeling what that looks like in a synchronous conversation, before inviting in siloed groups, because we need to, if we start with groups that sort of get it, and then bring their text chats or their asynchronous chats into the synchronous space that is virtually connecting, then we can go from there into, this is what we do, this is what it looks like, do you want to come in and join us, and make that a more open invitation. That's sort of an interesting, that's a good thought, actually. Like, that's what I'm sort of seeing now, and I'm wondering what you guys think. Does that make sense?
It does, and it also gets into the questions of barriers, because there are going to be some barriers for people around safety and comfort with digital spaces, but also that cultural shift we spoke of in the beginning, which is really about, is it safe and okay for me to share myself here? And there is not a red carpet for that. It's a very new way to be in the world, I think, for a lot of people. And I am speaking to some of my constituents that aren't even on, I don't want to say aren't even on Twitter, that's not really fair at all, but are just beginning to even consider Twitter as a safe space for themselves. So I think, again, that spectrum is going to be important to the modeling, is also to be at least speaking a little bit to some of that spectrum of comfort for ourselves that could possibly be barriers.
I think there's a couple of interesting barriers as well within the, we talk about Facebook groups, they work because they're private spaces, or they're seen as private spaces. And virtually connecting, I do not want to ever be seen as a private space. I think that the intent of it is that it is a broadcast space. We have not broadcast. I don't know. That's my thought. Anyways, I don't know what others think about that. In the healthcare community space, there are huge conflicts, because practicing, those that are providers are taught never to share patient information. But when the patient broadcasts their information and self-identifies, they don't know how to manage that in various spheres, because they're very much told not to. And we see that very much in the academic papers, and I see it particularly within the nursing field when they study blogs, and they can't deal with it's public information, but then how do I quote, or do I not quote, or do I not anonymize, because I want to protect identity. But you're protecting the identity of someone who doesn't necessarily want their identity protected. And so you have this really interesting tension, and I think it's a tension we need to bring forward and make it more clear that there is a tension there, and perhaps make it clear that it's okay if a patient wants to be identified, to identify them. Because that's part of the problem of that's part of the tensions, I think, in the whole discussion.
That's the nature of being at the frontier. We are at the frontier of change right now. And so that tension that is there is understandable. It's the way it has been, and there's defamation online. There's, a lot of modeling for very negative things that have occurred for people online. And so it's understandable that there's some fear there. And in the education space, that's a traditional way of teaching. And saying that things need to be private. So there's no blame there, but we get to be at the frontier of inviting a different possibility. And that's why this is so exciting, but also our work is cut out for us in being as thorough as we can to describing what it means to be in the public space, and asking ourselves what that means, and collaboratively coming up with a set of criteria or safety nets for each other, and that's part of this work as well.
Autumn and I both texted, we're coming to the top of the hour. We need to wrap up the conversation soon. So let's just throw out there, what are our next steps? Where do we go from here? When do we have, do we have another conversation? It sounded like Susan's actually got an action plan where she's going to take this someplace. I think I'd like to take it to some of the breast cancer Twitter communities to see if they would be interested in doing a sync chat, even about what they do, but also, just a sync chat. I don't know, what do the rest of you guys think? And what kind of timeline do we want to get back together?
So if I may, I'd like to just kind of continue to be a fly on the wall, asking questions and jumping in where I can and helping out with tech support. I've been on Twitter trying to talk us up a little bit here and communicating with a couple of people in back channels and trying to promote us and trying to be supportive in that way, especially because this isn't my research area. I find it fascinating, but I don't know how much I can really dig in, but I want to be of support in terms of digital literacies, in terms of, if you needed somebody who needed help with figuring out what a Google Hangout is and how to connect, if they needed a test run with somebody, I'm willing to be that kind of person and help out at, where I can and where I can find time for those kind of things. But just want to applaud you for doing this work, because I think it's really important in the ePatient sphere, but I also think it's huge in the digital citizenship sphere as well.
I like to call it digital health literacies. But yes, and we will also probably call upon you, Autumn, occasionally to help facilitate conversations, because you're such an awesome facilitator.
Thank you.
Do you have any thoughts, Brittany?
I mean, I could reach out to the endometriosis group. They've done similar synchronous type chats, but they're very private. It's very hard. Endometriosis is still very stigmatized, and so they're very uncomfortable. I don't know that they would be comfortable quite yet branching out into a live broadcast space. That the concept of safety nets and figuring out what kind of safety nets we can provide while still being live would be really important there. Because I know most of them, even like in the private Facebook group, post something saying, this is private, don't share, and then post it in the comments even further down, so that it's extra hidden.
Yeah, I think that it may be one of those things that we wait a little bit on. The reason I said BCSM is because it's a public Twitter chat that is well researched, and it's researched across various fields. So it's sort of like if you want to study social network analysis, it's one of the communities that gets hit for the studies most of the time, because they've been around so long and they're such an active community. And it has nothing to do with the topic.
Yeah.
In that case, but I think that then that may make them more interested. So, I'll throw it out there, see what they say, and try and throw out. And I think the blogging community is another one, right, that may be interested.
And I did tag BCSM in BCSM chat in one of my tweets, and they retweeted with their hashtag, so they're aware of this conversation at least.
Great, and I think we can also do our own, just a next step too. Is I would love if you find articles on things that talk about those safety nets and privacy edges and policies that can help edify me. Like, I need education around that to help articulate that, to wrap those liminal spaces that we're inviting people to come into, so that we can start to come up with our own languaging around that that's sort of in the field there. And that's what I hear what Brittany's saying, is that there's some knowledge there in some of your circles too, that we can all share that as we go to help us have these conversations with our constituents.
So I wonder what technology would be the best technology for capturing that. Like, is that like a Digo thing, or?
Oh, I don't know. We could do a Google Doc, to capture articles, or a Slack channel. that has info in there. That might be the best way, actually.
A separate Slack channel?
Yeah.
Okay, I can set up a separate Slack channel, VC EPT.
Well,
Not on virtual. Sorry, a separate Slack team. I would pull it out of the
VC.
channel.
really?
Yeah, because we do a lot of buddy stuff and a lot of VCs. There's too much background noise in the VC channel.
But if we're curating, and maybe I'm misunderstanding what we're doing. So are we curating a list of resources?
Yeah, it makes me. Yeah,
I kind of want that to be public because
I do too.
I almost kind of want to put a page on the Virtually Connecting website for that, so that anybody could get to it.
That's a great idea.
yeah, that'd be easy enough to do.
Yeah, and then we could reference it and point newcomers to it and that kind of thing. But just throwing that out there.
Yeah, I was gonna throw a menu item up.
Yeah, like a special menu item with
Yeah.
a drop-down list just for this new kind of area of focus for Virtually Connecting, and you could have
Yeah.
a resources page in there.
Because then I can tag, because I was going to tag all of the VCs related to this, so
Right.
people can just go to one place for them.
Right.
But I could also, when we set that up, I can set it up as a page.
Nice.
So it'll have the VC stuff listed in it, and then it can have other resources on sort of what different things mean and what might be useful for people. And we can just sort of categorize. I think that's a brilliant idea.
Go team.
Go team.
Okay, I gotta run, ladies.
Yes,
All
we're
right.
going to have to shut down the live stream. So thank you, anybody who's listening or watching later. We will try and have a follow-up conversation. Probably, I'm traveling for a couple weeks, so when I get back from Ottawa, so probably mid-July. We'll try
Sounds
and
great.
pull this
Thanks so much,
together.
Rebecca. This was so wonderful. Thank you.
That's a planning one. We'll try and do other ones as needed because we're very flexible. Okay, take care, everybody.
Bye, everybody.
Thanks.
We're
Bye.
going offline. Bye.